going to talk about a little bit of the normal gait cycle, and then the biomechanics to make you understand how the lurch is on which side, on the affected side. And then I'll talk about a little bit of short limb in towing gait, cane in the opposite hand. If you permit me at this time, then I'll talk about the last two. Otherwise, I'll just stick on to the gait cycle, which starts with the heel strike, then goes on to the foot flat, then is the mid stance, and then the heel off, then the toe off. Then the swing phase starts when the limb is off the ground, starting from the initial swing to the mid swing to the terminal swing. And then the foot again, when it strikes, the heel strikes. That is the finish of the one gait cycle. And one gait cycle consists of 2 steps. So there are other terminologies for this. Instead of heel strike, it is the initial contact, because for example, if there's an equinus, the heel will never strike. So it's the initial contact. And what's important is the foot flat. During the foot flat, there's actually a loading response, because the body weight is now getting loaded onto the foot and ankle, right? And the mid stance is actually where it's a single limb stance, where the opposite limb is off the ground. And this is 40% of the gait cycle, right? So during the mid stance, most of the pathologies get revealed, whether it's the Trendelenburg gait, whether it's the antalgic gait, because in the antalgic gait, the patient will not stand on a single limb stance for a long time because it's painful, right? And we look at, as I said, the single limb stance is only 40% of the 60% complete. If you look at the biomechanics to understand hip pathologies and gait, the biomechanics taken from the physics levers. The first class lever is where the fulcrum is in between. So the load here is the body weight. And you know that this, to make this balance, so the body weight and the body weight lever arm, this product has to balance with the abductor effort, which is created by the forces of the abductor muscles to balance this. So abductor lever arm. So body weight lever arm and the abductor lever arm, when it matches, then on a single limb stance, this the body is balanced and doesn't lurch anywhere, right? So if we stand on both limbs, right? So what is the distance between the 2 feet? That is around 5 to 10 centimeters. So the body weight, which is around the weight of the head, the trunk, and the upper limb, that consists of about 66% of the body weight, right? The 66% of the body weight is equally divided into 2 hips when the person is standing on both limbs. So around 1/3 body weight on both the hips. Now the moment the person stands on one limb, let's say this limb, then what is happening? This is the 66% of the body weight plus the weight of this limb. That has to be borne by this, or this hip, right? When it's standing on one limb. So that means this body weight is increased. So on standing on one limb, the hip abductor forces have to be much more, because this product has to balance this, right? So the hip undergoes a much more pressure, and the abductor forces are much more on standing on one limb. Now, if you look at another aspect of physics, you all know that the center of gravity should pass between the base, right, to make a person stable, right? So the center of gravity here is in front of the S2 vertebral body, and that on standing on both limbs is passing in the base, which is the distance between the 2 feet, that is 5 to 10 centimeters. So on standing on 2 feet, the person is pretty stable and he can sway on one side or the other, because the center of gravity will fall within this base, which is a 5 to centimeter long distance. But the moment he stands on one limb, so what is happening? So let's look at the center of gravity. Now, instead of the 5 to 10 centimeter, it has become like a cone. So the center of gravity has to pass through this, only through this foot. So if he is going to lurch on the opposite side, the center of gravity will go beyond this. It's like an inverted triangle, inverted cone. The cone is unstable in the point pointed here, and more stable if it's the reverse base here. So one is the center of gravity goes away and the patient becomes unstable. The other thing is what's happening. So when he's lurching on this side, so if you see this diagram, when he's lurching on the side, which is on his weight bearing, so the body weight lever arm is decreasing. So the product of the body weight and the body weight lever arm is less now. So the abductor forces have to work much less. So in antalgic gait, the abductor forces are less, so the pain becomes less, right? And in Trendelenburg gait also, so when he's lurching on this side, so this the abductor lever arm and the the abductors are now able to balance this far better rather than if he was lurching on the opposite side where the body weight lever arm would have increased, right? So in any type of gait, when the person is standing and putting weight on one lower limb, the lurch will always be on the same side on which he's standing. Why? Because the center of gravity has to come here and the body weight lever arm decreases. So this is a more efficacious biomechanics for the hip. So having learned this, let's look at this video where this person is standing on the normal limb. We asked him to stand on the TB hip patient on this side. He's doing a trick movement. I'll explain that later. But we tell him to move this. So now he is, lurched on this side. Lurch means sway of the trunk. So when he is swaying the trunk on this side, what is he doing? So the body weight lever arm is decreasing, right? And the center of gravity is now coming to lie in this small foot compared to if it were on starting on both limb, it was much wider base, right? So what was he doing by this trick movement of putting the weight on the left side? Let's look at it again. So when he asked him to stand on the affected side, this is like putting weight on a cane on the opposite hand, right? So when he was pushing like this on a cane, so the moment, turning moment which is created when he was standing, which was trying to fall the sides, the turning moment is now offloaded by the pushing action, and this pushing action creates a ground reaction force, which helps to, the turning moment is now turned this side, right? So you have because of the ground reaction force, the pressure is coming back again. I'll talk about this in the last slide again. So the Trendelenburg gait, Dr. Kapoor had shown very well, is like in other pathologies where affected side, the lurch is always on the affected side. Now let's go to the, in case of this is a patient with a hip dysplasia. In fact, it's a skeletal dysplasia, multiple joints, and it's got a bilateral Trendelenburg gait. This is known as a waddling gait. So he's waddling like a duck, right? And now we go to antalgic gait. Now the characteristic of antalgic gait is, as I was telling in the normal gait cycle, that the mid stance, where 40% of the cycle, where the entire body weight is being borne on a single limb. So obviously it is going to be painful. So that part of the mid stance phase is going to be much reduced so that the pain is less. And most of the time patient might be taking a double support, right? Because he's not having a loading response and a single limb stance. So he takes a double support. And very important is the stride length of the opposite limb that decreases. I'll show it how this happens on opposite in the next video, because here the moment he takes a longer step length on the opposite side, he has to, that means stand on one limb, which is the affected limb, for a longer time. So that is causing more pain. So he will take a shorter step on the opposite side. And as I discussed earlier, the lurch will always be the same on the same side, because on being on the same side, the body weight lever arm is decreasing. So the product of the body weight and the body weight lever arm is less, and the abductor forces are less, right? So it is less painful. So if you look at this video, it's all double stance, okay? Double support. Now, the single limb support, mid stance, is very short. It's very painful. It's an active disease of tuberculosis, very short. And which means that he will lift the opposite limb and take a short step, because if he takes a long step, he will have to stand on this painful limb for a longer time, which is very painful. So this side will be short, and the mid stance, obviously, where the entire body weight on a single limb stance is there, is very, very short. And if you look at the lurch, so he's going to lurch on this side, the same side, affected side, right? So next gait is the short limb gait. The short limb gait, as Dr. Kapoor described, is a vertical dip of the shoulder, right? So if you look at a disease where is only pure short limb, for example, there is a malunion of the tibia, right? And the hip is normal. So if he's walking, the hip is normal, biomechanically the joint is okay. So when he puts his, on the stance phase, he walks, so the shoulder will come down and the pelvis will come down, okay? But in reality, what happens is that a person with a disease of the hip has got multiple things. He may, because there's a disease in the hip joint, so the disease in the fulcrum, okay, or the lever arm, so the Trendelenburg component will come in. Because it may be painful, antalgic component may come in. So there could be a mixture of everything. So in the exam, some of the examiners like to ask, okay, you tell me, because the candidate starts answering that, okay, this is antalgic also, and this is Trendelenburg also, and short limb also. So some of the examiners like to ask, okay, out of these, which is the most predominant? Like in the video of the antalgic I showed you, the predominant was antalgic, right? In the video of the Trendelenburg, it is purely a Trendelenburg. Now this is a patient again of a hip pathology. Very, you can see the subtle dip of the shoulder, and there is a lurch. So now there, whether there is a Trendelenburg component, so you give a shoe raise and you compensate the limb length shortening which is there and make him walk, and you find that the vertical dip is less,
Dr.
but
Sumit,
the Trendelenburg
please be
component
fast.
is not revealed.
Dr. Sumit,
This
please be fast.
Trendelenburg component gets revealed, and this sometimes, you know, when we used to do polio surgery, this is where we have to explain to the patient that there's a hip pathology and there's a shortening. So if we compensate the shortening by limb lengthening, then the Trendelenburg component becomes more, because that gets unmasked now. Because earlier the Trendelenburg lurch was getting masked by the vertical dip. Now the vertical dip is gone, and the entire thing becomes a lurch of Trendelenburg. So another example, vertical dip and a lurch. Okay, Trendelenburg plus short limb, and when we give him shoe raise, the lurch is slightly more. Now this is a case where the limb length discrepancy is very severe, 25 centimeters, imagine, because of the proximal femoral focal deficiency. And we ask the patient to stand. So you can look at the vertical dip there, vertical dip of the shoulder and the pelvis, so unstable, right? So that is a typical short limb gait, vertical dip downwards.
Dr. Sumit, please summarize now.
Okay, so I can finish. I've talked about the three main this thing. I don't want to go ahead and waste time, because the rest is not so much important. Yeah, thank you.